I'm going to start by introducing Paul, and this is this is really very special for me. You've heard me talk about Wendell, Idaho, my hometown of 23 of about 1,000 people, 1,132, when Paul and I were growing up in Wendell, Idaho. So we go back a long, long way, and it's just uh, so special today to be interviewing Paul 65 years later because, and I've told you, Paul, you were my childhood hero. So here's a guy that was 4 years older than I was, and I was just, I adored him. He was the quarterback on our football team. He was the student body president. He got admitted into to Stanford, and so he was, I was so fortunate to have somebody in my life that I could look up to and say, if I ever grow up, I'd like to be like Paul Miles. So isn't this special? He's a Medvalista. He's in our Sages Club. And Paul, I mentioned this to you earlier, but on our Monday staff meeting, Tiago and Maria said, we wish we had had Paul as our physician when we were kids. So, Paul, that's some kind of a ultimate compliment uh, from some more of your admirers. So, Paul is, I'm happy to say, not just a Medvalista, but one of the very first Medvalistas. So he goes back with our little town a lot. A member of our Sages Club, been a thought partner to me for these last 5 years of putting this idea together. And Paul, I don't know if you remember, but at a cabin at Redfish Lake, we sat around and designed the idea of a dolphin tank. So
Yes.
he's got his fingerprints all over that product as well. So at the end of this 45 minutes, before we go into the open discussion, you're going to know three things. First of all, why co-produce your own care? Secondly, what are some good models that organizations are doing to enhance this? And then lastly, the impact that you've had, Paul, or the impact of Medvel and your Medvel Club on you. So let's dive into this. And so, Paul, talk about your journey. There's a lot of people even on the call here that are moving from a clinical involvement to being a leader in healthcare. You've certainly done that. You're a physician thought leader. You're passionate about safety, about quality. You've given presentations in all of the 50 states. So quite a trajectory. And so tell us a little bit about your story, Paul.
Oh, thanks, Jim. Well, yeah, I've been a fortunate person. As Jim said, I grew up in a small town. I'm a fourth generation Idahoan. My ancestors homesteaded in Idaho in the 1880s. My dad rodeoed for a few years in the Jackson Hole area. So I grew up in a small town with a lot of strong support. Neither of my parents went to high school, so I'm a product of public education. But when I was in high school, I got a job shoveling coal for a lady named Mrs. McQuivy, who was Jim's grandmother, whose house was right next to the high school. And we were talking one day. She was really a neat lady. And she said, I hear you're a pretty good student. I said, yeah, I do all right. And she said, well, where are you going to go to school? And I said, well, I'm not sure. And she said, well, you should consider Stanford. And I said, I don't want to go back east. And she said, wait a minute, Stanford's in California. So I ended up, because of Jim's family, that I ended up applying to Stanford. Our roots go way back. Well, I went to Stanford, started out as a physics major, decided that I loved science, but it wasn't personal enough. So I switched to medicine. Went to medical school, and I think medicine is a wonderful combination of science and people. Um, and then in medical school, I was on an MD PhD program, still trying to combine science and medicine, and then rotated onto pediatrics and fell in love with the idea of helping kids and having an impact on the rest of their life. But I was fascinated by growth and development. Anyway, so I went into pediatrics and almost went into an academic career, but I did not like living in big cities, did not like killing guinea pigs and working in labs. So I went back to Idaho because I like to fly fish. I like the mountains. And I practiced in Twin Falls, which is a town near where Jim and I grew up, for 24 years, general pediatric practice. But I got really frustrated. The system just didn't work for kids. By kind of serendipitous, got to learned about quality improvement, and the local hospital that we worked at was a county hospital, but we started doing some work nationally with Don Berwick and the Institute for Healthcare Improvement, and we had this model or a vision of creating the Magic Valley, the area where our hospital was, the healthiest place in America to live. So that was really a grandiose idea, but it was kind of attractive. And people said, well, what are you trying to do there? So I did that for about 5 or 6 years and started deciding that I could keep seeing individual patients or maybe try and change the system. And eventually I got recruited away from Twin Falls, Idaho to Nashville and became the chief quality officer at Vanderbilt Medical Center. And I did that for 3 years, but I really didn't like working with adult patients as much as kids. So I had an opportunity to join the American Board of Pediatrics on their senior leadership team in Chapel Hill, North Carolina. And the part I was involved with was helping physicians measure and improve quality of care. Um, so I did that for 11 years, and that was a wonderful kind of a dream job for me. And had a chance to travel all around the country, travel some in Europe, looking at how do you create systems that help physicians measure and improve quality of care. And then retired, came back to Boise and where I could fly fish and be in the mountains, and have been back here for the last 10 years. And then I've gotten to know Jim, and been wonderful to reestablish that friendship and get involved with Medvale. So that's been my kind of career. Um, I could talk about my career now as being a patient.
Mhm.
Can I hear that story, Jim?
Yeah. So it seemed like a lot of healthcare inspirations and uh, innovations have come from people having a patient experience, often unsatisfactorily. And so, Paul, in our SAGES conversations, you've been talking about um, ideas you've had, complaints, and the idea that I think that makes us better healthcare leaders is to experience it from a patient standpoint, as we maybe have gotten, oh, if not jaded, just kind of routinized about what we do. And it could be a good wake up to be on the other side of that. And Paul, that seems to have informed some of your impressions about healthcare delivery. And so, yeah, why don't you talk about being a patient and what that did for you?
What profoundly changed my career was a medical student. I was, 15 years into my career and got interested in quality improvement. And there, the idea is the quality is really measured by the people receiving the care, not necessarily the people delivering the care. But she asked me this question. We were looking at variation in healthcare, and there were some physicians in our community that were doing this new procedure, and we wondered whether it was really appropriate or not. And she turned to me and she said, "Well, Dr. Miles, how do you know what you do works?" And I said, "What? Yeah, yeah, well trained. I practice perfect medicine, right?" When I really started to look, I really did not have data to to show for sure that the care I was recommending, that I was betting the lives of kids on the care I was delivering, and I didn't know for sure whether it worked. And when I started to look at that whole area of variation across healthcare, the Dartmouth Health Atlas and all the other data, there's tremendous variation across American healthcare in terms of outcomes across systems. And when I went to work for the Board of Pediatrics, there's variation in knowledge from physician to physician. So that idea of kind of looking at variation of care was a critical issue. But my very first day at Vanderbilt, after I left Idaho and arrived in Nashville, um, I was carrying some boxes up to my office and developed some chest pain. My father had died of a heart attack at age 53. So I thought, whoa. So I, like most people, denial. I sat down and said, maybe this will go away. And after about 45 minutes, it was getting worse. So I walked over to the office of the physician I was reporting to. And I said, John, I said, I think I'm having a heart attack. Well, he turned kind of ashen white and he said, Paul, can you make it to the emergency room? So we walked slowly down some stairs, the emergency room, and the receptionist said, okay, what's your name and health information? And John said, forget that, and pushed through the door into the emergency room, laid me down on a bed. And 30 minutes later, I'm in the cath lab getting stents placed by a cardiologist, then a former astronaut who became a good friend. That changed my life again because all of a sudden I realized that, you know, when you're on the healthcare delivery side, you see patients as the other. But I think for all of us, we're all patients at some point in time. And that began my journey of trying to be a great patient, or at least continuously be a better patient. And that has been progressive over the last 25 years, trying to become as expert a cardiology patient as I could be. But I became, after I retired, realized one of my full-time jobs is kind of being a patient as you acquire more problems. So this idea that I think for all of us, being a patient is a really important job. I think for all of us, we want to live as long as possible and have as meaningful a life as possible. And there are all these articles written recently about, you know, those factors that influence that, having strong social connections, exercise and mobility, good nutrition, good sleep, handling stress. But the factor that a lot of people don't mention in those lay articles is managing your healthcare problems and your interactions with the healthcare system is critical. And you can play a role in being a better patient that may have an impact on getting better outcomes, of less frustration with the system, and maybe even saving your own life. So I've really become interested in this, and I have like a checklist of what's worked for me, of like, and I'll just go through that quickly, 10 things that have worked for me. May not.
Well, and Paul, let me add that when Julie and I moved to Sun Valley, we needed a new set of doctors. We used Paul's checklist to interview our doctor, the potentials, and it worked. It was different, uh, but what a good idea. So uh, I just want to give you a testimonial that
Okay.
Paul's
Well,
checklists are worthwhile.
well, that's one of the things, you know, I recently I went to Mayo Clinic for an ablation because I have a long history of atrial fibrillation. And the questions, one, I called and kind of researched who I wanted to see. And I called and said, I'd like to see Dr. Noseworthy because I had known his father a little bit. He was in mid-career. He was an electrophysiologist. So he called me back and did a phone interview and asked me a bunch of questions. And I said, let me ask you some questions. I said, how many of these have you done? What's your outcomes and what's your complication rate? He said, Paul, he said, I've done 1,700 of these. And he said, there's an 80% chance that you will have no more episodes of atrial fib in the next year or have significantly fewer episodes. He said, in terms of complications, I've had 2 patients go to surgery, but nobody's died. And my next question to him was, and you'll do the procedure, right? Not one of your fellows or somebody. He said, I'll do the procedure. So I flew back to Rochester, had it done as an outpatient, went back to the hotel that night, came home, and I've done really well. But I think that idea of how do you choose a physician is one of those key issues, and not being afraid to ask physicians what their expertise is and what their knowledge is. And if they can't tell you that or feel uncomfortable with it, maybe looking for some other. And so let me go through my checklist really quickly. And you know, this is an hour and a half talk. So if you want more information, I'd be glad to supply that. or if you wanted to talk later. But for me, it starts with kind of the right attitude. I think believing that um, managing your healthcare problems in a different way, that you have a role with that, is a critical issue. And so I ask people, how good are you at co-managing your own care? And I would ask that question to each one of you if we were in individual discussion. And what I found is that physicians aren't any better than anybody else. A lot of people are just kind of passive. Tell me what to do, and I'll do it. But I think having an attitude that is respectful, but assertive. I think respectful in the sense that we all have had bad experiences with healthcare, or our family have had bad experiences with healthcare. Most of the time, those are system issues. Most people in healthcare, nurses, physician care team members, want to do the right thing. And I think you have to cut them that slack and say they're there trying to do the right thing. The key issue is then what's wrong with the system. And providing that kind of feedback is absolutely critical. So if the first thing is having the right attitude. So my checklist is this. I have a health plan I develop every year. I mean, we all have retirement plans. We all have social calendars, what we're going to do in the coming year. We have maintenance for our house, our cars and stuff. I kind of look at all my problems and say, what do I need this year from the healthcare system? Because in those other issues of nutrition and exercise, those are all things that we can do ourselves. But when we have a problem we can't, and we need expertise from medical professional, we become what are called patients. And that's a specific role. As we all know, there's a difference of power structure, and they invade our privacy, make us take off our clothes. We have to tell them all these stories. Um, I think so. Being assertive and being respectful is a critical piece. But developing a health plan is the first step. The second thing I do is I think everybody needs a health team. It's difficult to be a great patient or a better patient by yourself. In fact, I think it's impossible. You need somebody to help with logistics. You know, when I go in for a colonoscopy and I'm sedated, I can't drive myself home. My wife's a nurse. She's my logistic person. Um, but you need a second person who you can share confidentially what it means to have a problem or what it means to get older or whatever. So my wife, I do that with, but I have two physician friends, and we have this wonderful dialogue back and forth of the problems we're facing and how we're dealing with those. So I think having somebody who you can help on the confidential, a third member of the team, somebody who can go out and do literature research and understand the language and explain to you what your problem is. Now, as a physician, I have kind of a leg up because I do that myself, but I serve that as a care team member for some friends as well. But I think having the ability to go out and research the literature so you really understand what your problems are and have explained in a way that you can interpret that. But probably the most important part of your care team is having a really good primary care physician. And almost everybody I've talked to who's really satisfied with their health care has a good primary care physician, somebody who knows you as a person, somebody you trust, somebody you know is going to act in your interests, somebody who is going to refer you to a specialist if you need it, coordinate that care, and understands wellness as well as just the medical model. And so I have a kind of a checklist of how do you pick a good primary care physician, or if you have a good primary care physician that you'd like to improve your relationship with, how do you do that? So forming that team is critical. The next step is every visit. I write out a plan, what I want out of that visit. You know, what answers do I want? What do I expect from that? So I go into it. What information do I need? But every visit, I write out a plan before I go. And sometimes I go over that with part of my care team if I have a question. I think once you get to the visit, then there are two really important things. And one is being able to tell a personal story. And you don't want to tell your whole life story like Jim asked me to do, but you know, really concisely. It's important, I think, for the care team to know who you are as a person. You know, I tell them I'm a retired pediatrician. I'm a retired chief quality officer, so I'm going to ask some uncomfortable questions. You know, I like to fly fish. I'm active. I still travel. This is what's important to me. So they see you as a person and not just to hear somebody coming in complaining of chest pain. Secondly, is telling your medical story. I think there's no question that medicine is kind of a different language, okay? And physicians think in a way that helps them get to the right diagnosis. And if you can tell the story, for instance, if you come in and say, gee, I've got my side's been hurting, okay? Well, that's different than if you say I've had episodic episodes of right upper quadrant pain that's, maybe intensity of 5 and it's relieved by Tylenol. There are ways you can tell your story that actually help the care team make the right diagnosis. I have a whole checklist of you can fill out that talks about your genetic history, your review systems, your past medical history, all of those kind of medical-like terms that most lay people don't understand. But if you can talk in those ways, but keep it concise, and that's where having your team help you as well, can actually make a difference in terms of getting to the right diagnosis. So telling a personal story, telling your medical story in the right way makes a difference. And then you're going to go through the whole process and kind of understanding that the physician's going to ask all this stuff. They're going to do an examination, maybe order some tests, and then they're going to get to a diagnosis. And I think getting the right diagnosis is critical. 800,000 people a year die in American healthcare system because they get the wrong diagnosis or don't get a timely diagnosis. So if somebody tells you you have chronic kidney disease, say, what does that mean? Okay, tell me what that means. So understand what your diagnosis and agree with it. If you feel uncomfortable at all, ask your care team or ask for a second opinion. Ask, could this be something else? What are the tests that, so keep asking until you're pretty comfortable that that's the right diagnosis. That's a critical factor. Next thing, then, once you get the diagnosis, they're going to recommend a treatment. And again, it's the same thing, asking, what are the alternatives to this treatment? What are the possible side effects? What's my prognosis? There are a whole bunch of questions you can ask that make sure you understand what the treatment is, because getting the right treatment, getting the right diagnosis and the wrong treatment isn't going to help, or getting the treatment for something you don't have. It's critical to make sure you get the right treatment. And asking questions, is there another specialist I should talk to, or is there a place I should go for treatment that's better? What's your outcomes at this particular facility? I'm surprised the number of people who are reluctant to leave the local community to go for additional advice, like Mayo Clinic or Cleveland Clinic. I mean, if you have a cardiac problem that's really unusual, why wouldn't you go there? It cost me $250 to go to Mayo Clinic. It was no more expensive other than the travel and the lodging. So getting the right diagnosis, getting the right treatment, and then understanding what your role is in that treatment. And that's part of this idea of co-producing your own care, and accepting that, okay, this is exactly what I need to do to get better. And knowing what your follow-up is. Who do I call? What do I do if I'm not doing well? When do I next need to be seen? What's the kind of course of what's going to happen? So I think that follow-up is important. And then the next step, I think, is being the best possible medicine taker you can be. And that's an enormous issue in healthcare. I think we're all probably on medications. Anybody on this call who's not been prescribed a medication, it'd be really unusual if you said no. But there's a lot of good studies that 50% of prescriptions are never filled. 50% of prescriptions that are filled aren't taken in the right way. So it doesn't do any good if you get a prescription and you don't understand what it is and you don't take it in the right way. So I have a checklist of how to be a great medicine taker. You should know, if you don't know the names, and have them written down, but you should understand that medication is going to help my blood pressure. That medicine is going to help this. That's going to help that. And am I taking them in the way that they prescribe? What are the complications of that medication, to the side effects? I've had a couple of adverse events from medications. A cardiac medication was prescribed, an erythromycin antibiotic that was directly contraindicated for use with that medication. If I hadn't known that, I might have filled the prescription. In fact, the data is that like 40% of people have had a medical error. So being the best possible medicine taker you can be is actually a critical part of being a good patient. And then finally, kind of the last thing is anticipating going forward. So I have a checklist if you go in the hospital, or what to do if you to be a better patient in the hospital. Asking people to wash their hands, putting something on your bedside that tells who you are as a person, having somebody there with you all the time, if at all possible, questioning every procedure that they're doing, or if they come in to give you a medicine, say, gee, what's that for? Same thing for surgery, same thing for emergencies. And then I think part of being a great patient is looking at, especially if you get to my age, end of life. And I would recommend Atul Gawande's book, Being Mortal. But I think having advanced directives, having those ideas of how do I get to the end of life and make it as hassle-free as possible for those people who are going to have to take care of me after I'm gone. And there's this wonderful woman, Joanne Lynn, who has this definition of a good death. She said, plan for a good death. And her definition is uh, in my own bed, in no pain, in skin to skin contact with somebody I love. I thought, yeah, I could buy that. Finally, I think the other advantage of becoming a better patient or a great patient is you help other people to be a better patient. I'm doing a lot with my kids to try and inform them because we have a strong family history of heart disease, what their risks are. But I've got a bunch of colleagues, physician colleagues, who in the last few years have developed atrial fibrillation. So I've become kind of a sages club of AFib retired physicians. But I think it's just a really important, if you want to live a longer life, a more rewarding life, then looking at it from the perspective of how do I co-manage my own care and realizing that you can make a difference in terms of how you interact with the healthcare system to get better outcomes, less frustration, and maybe save your own life. So
Yeah.
that's kind of my journey is trying to be a better patient. And one other thing is that my wife keeps reminding, well, you may think you're a great patient, but you're not a great female patient. I say, no, you're right. These are kind of individual stories of what's going to work for you. So testing some of these may help. Um, I kind of know what it's like to be a great patient for pediatrics because I've been both a pediatrician and I've had kids with health problems, but I have no idea what it's like to be a great patient as a woman or a great patient with cancer or a great patient for a lot of other problems. So I think this is tailored, you can tailor it to fit your own needs. Okay.
Thank you, Paul. And the idea of co-producing your end of life care is so interesting. And one of our other members in the Sages Club, Paul, you may recall, says, "Die like a doctor." Doctors die pretty well. It's thought about it. They're uh, dry skin contact with people they love, typically in their own home, dry, warm, comfortable. So a lot to think about there. Now, Paul, you talked about the checklist. Could MedBallistas have access to that? And your email is at the top of the chat. So is could they get a hold of you to talk about that or let Tiago know and he can pass that on?
Yeah, yes, I'll send Tiago that kind of 10-point thing. There are no experts, I think, in this. There are things that I think can work for a lot of different people, but there's probably nobody who's an expert on being a great patient. What works for one person may not work for the other. So I think these are principles that work for a lot of people. You can test them and see, but I'd be more than willing to share this. And let me just reference, I've learned a lot from a guy named Leslie Mickelson who wrote a book called The Patient's Handbook. And I can include some references as well, websites that I kind of trust. I think health-wise, Jim Jeffrey, there are really good sources for helping patients acquire medical knowledge. Um, but I use, like Mayo Clinic and Cleveland Clinic for pediatrics. I use Children's Hospital of Philadelphia and Cincinnati Children's. There's some really good websites out there that I think you can trust in terms of information.
Well, and if you want to put a link into the chat, please do. And uh, uh, Jim Gouffre was the president of HealthWise. That content helped a lot of patients to do this in a much more thoughtful way. Now, Paul, you've always been pretty positive about what we can do. And you've worked with some systems that have had some extraordinary results that we can be inspired by. We've got, 10, 15 more minutes before we go into the open discussion. Could you talk about some of those that seem to be doing a good job that we can take a page out of their book?
Yeah, I've always believed that you don't always have to reinvent the wheel. Go out and find something that's succeeding and then modify it to your local situation. Halfway through my career, came across this concept of co-production of care with some folks like Paul Batalden, who's a retired professor at Dartmouth, some folks in Europe, in Sweden. And the idea of co-production of care is goes way beyond, I think, patient-centered care. Patient-centered care is kind of the healthcare system thinking about what the patient may want or need. Co-production of care is really saying that for any service, especially in healthcare, quality is determined by a partnership between the person receiving the care and the person delivering the care. And so looking for examples of, and that's at the level of designing the healthcare system, delivering the healthcare system, evaluating it, even involved in the research. So are there models, really good models of co-production of care? And there are, I think, and I've been inspired by those as models of maybe how we should be designing healthcare in this country. And the one I'm really enamored with is the cystic fibrosis story. Cystic fibrosis is a genetic disease. Um, right now, it's a life-limiting disease. When I first started practice, people with CF lived an average of 21 years. Now they're living 56 years. And that idea of how did that happen? Well, there are about 40,000 patients in this country with cystic fibrosis, adults and children. Mostly it was a children's disease for a long time. Years ago, they formed a foundation and started raising money, the CF Foundation. And they invested in a registry where they kept track of data for every one of these 40,000 patients. And for years, each center would collect their data, but they wouldn't share it. And they were making some progress in terms of extending lifespan. And they've always had this big dot, and the big dot was how do we help people with CF live longer? Well, about 20 years ago, Don Berwick and some other people kind of challenged them and said, if you really want to make rapid improvement, then develop this as a collaborative effort. So they took about 2 years to convince people to share their data publicly, their outcome data by center, and there are 130 CF centers across the country. So they started opening this up, and they said, okay, lifespan at this center is like 24 years. This center, on average, it was 24 across the 130 centers, except for one center in Minneapolis, where it was 34 years. They said, whoa, what's going on there? So they went there, and the guy named Dr. Warwick was doing CF in a different way. And they realized that by creating a learning collaborative and looking who was doing the best job, it wasn't about who was doing the worst job. It was learning about the best job and then spreading across the whole system. So they agreed to kind of all standardize their care. So no matter where you go now in the country with CF, you're going to get the best possible care. They agreed to then start testing new ways of doing CF care in a systematic way, rigorous quality improvement. So they say, okay, we'll propose a new change, but we'll test it first to see if it works. In having that data, and then they started partnering with patients. And I remember at Cincinnati Children's Hospital, they said, when should we send kids home after we've had them in the hospital? And the parents said, well, we're the experts. We know what they look like. So they said, okay, you write the discharge orders. But they've created this network where the patients at the CF Foundation help design the system, and they help manage the system, govern the system. They're involved in the delivery and in the research. And they have an equal, every improvement effort they do has a patient member as part of that. Their board of directors, the chair is a patient with CF. And what's really dramatic is that their current reserves are $4.2 billion, okay? And the way they got to that was a guy named, last name of Bell, came in and said, we've raised money, we have this philanthropic mission, but let's take part of that money and invest it. Let's become entrepreneurs. And so they have what's called venture entrepreneurialism. They took part of their CF money and they found a young researcher had a great idea for developing a new drug for CF. And they funded his research, funded his salary, funded his laboratory, and they got some of the royalty rights. And it was wildly successful, has profoundly transformed the lives of a lot of people with CF. Well, they just sold the royalty rights to a pharmaceutical company for $3.3 billion. So that's why they have so much money. They're investing about $200 million a year in new research for CF. But the whole enterprise is run as an equal partnership between the experts, the clinicians, and the patients in terms of, so the board of directors directs the funding of how that $4.2 billion is spent, but it's all done around the kind of the best science, the best commitment. That model has now been, well, it was not developed just by CF alone, but in parallel with a lot of other problems as well. There's now a learning health network like that for HIV, for congenital heart disease, hypoplastic left heart, for adult rheumatology, for adult inflammatory bowel disease, pediatric inflammatory bowel disease. There are about 10 or 12 models like that. But it's because the clinicians and the patients have partnered together, and that cuts across insurance companies, across academic centers, across the whole country. These networks are forming based on patients and the clinical teams. So it's a model, I think, that if you want a system, and the outcomes have been outstanding. It's evidence-based. And now the average life expectancy for people with CF is 56 years and growing significantly. So that's my best example of co-production where the patients and the care team have an equal partnership.
Well, I think that's inspirational. That has some application to what we do when we get off the call this afternoon. So, Paul, while I'd like you to talk about the last pearl in the time we have left, about how have you been impacted by MedVal, about your MedVal club, and why don't you talk about this while Tiago, you're putting up the survey. By the way, the survey last time taught us that we should give the take homes at the very beginning. So your input is appreciated and is used. So Paul, while Tiago's pulling that up and while folks are filling that out, tell us about, again, the impact of what MedVal's doing on your life.
Well, Jim, when I retired and moved back to Boise, you kind of lose the contacts you had before, the people I'd worked with back in North Carolina, the organization that I was with. And you kind of come back and a few people because I grew up here. But when you retire, you kind of lose a format. You not have an organization to speak from. And I think a lot of you probably, when you're retired, sometimes your voice isn't heard. But what I was fortunate to get back in contact with Jim, with John Bingham, there were 6 of us that kind of serendipitously got together and started talking about our experiences. And combined, we had like 240 years of being involved in healthcare. And we started these conversations around kind of our experience in healthcare, but it was experiences about what's it like to retire. Some of us had retired, some were approaching that. What's it like getting older? What's it like having medical problems, being an adult parent? We've talked about all kinds of things. So it's been this wonderful combination of having a safe place where you can talk about work-life balance. Okay, what's important to me personally, but what's important to me in terms of trying to pass on the knowledge I have or maybe the influence I've had. It's been fortunate. It's led to me getting involved with the local healthcare system to maybe have the opportunity to try and change healthcare locally that could impact patients, kind of what I've been trying to do my whole career. But it's giving me this network of being able to link with people around what it's like to kind of live personally. And what I've taken from that then is I have some really good friends that I worked with in the Board of Pediatrics, pediatricians, former deans of medical schools and chairs. And we formed a group of 7 of us. And so I've started another Sage Light group, and we talk every month. and they keep saying, Paul, this is really important. This is kind of the highlight of my month. Three of them have wives with dementia, so we talk about that. A woman just lost her husband, so we talk about kind of where pediatrics are going, where our lives are going. And then I have another group that I'm with that involves a really close friend who's in England in healthcare, two pediatricians in Sweden, and then three other people who I've had a long-term interest in quality improvement and health education here in the States. And again, once a month we get together. We talk about kind of what's going on in our personal lives, or where we think healthcare is going, comparing across systems. So the SAGES concept of this combination of being able to talk with people in a safe place about what's important to you personally, but also, kind of what's important to you in terms of healthcare, which is kind of what links us together, has been really enormously important to me. And I'm deeply indebted to Jim. He's kind of a master of getting people to kind of get together and talk. Um, it's been really important.